Alright, so we'll talk about respiration and ventilation. Keep in mind these are two separate things. Ventilation is actually the air moving in and out of the lungs, where respiration is the gas exchange between the tissues. In other words, it's the oxygen going into the blood from the air that we breathe into our lungs. And that process of the oxygen moving from the lung into the blood is the respiration. So it's sometimes we talk about them interchangeably, but they're actually two completely different terms. Respiration again is a gas exchange, and ventilation is that mechanical process moving air in and out of the lungs. But we'll talk more about those in this section. So what we'll talk about, and these will actually be broken off into different videos to make it a little bit easier to view. But in this one, we'll talk about the review of the anatomy and respiratory system. So mainly just the review of the anatomy here. In a different video, we'll talk about the mechanics of ventilation, that how do we achieve that mechanical process of getting air into our lungs, and then how do we exhale. And we'll talk about that process of respiration. We'll talk about the nervous system control over breathing. It originates in the brainstem, that vital function center of our brainstem, and that actually controls breathing. And then we'll talk about the different problems associated with airway, with ventilation and respiration, the different things that you'll see in your patients who are sick, so the actual pathophysiology. So let's begin with just a little bit of basic anatomy of the respiratory system, and this is everything out of the previous chapter. So the respiratory system, we're talking about the lungs and the airway structures. So the airway is how we get air from the outside down into our lungs. The different structures that you see, of course, the nose, the nasal passageways, the mouth, the pharynx, which is the throat. And so we have a nasopharynx and an oropharynx. We'll talk about that a little bit more in detail later. And the epiglottis, that's that leaf structure that closes over the larynx when we swallow food. The larynx, which is the voice box, the trachea, the different lung structures. So we'll talk about all of these in detail as we move forward, but this is the basic anatomy. The airway structures and the lung make up the respiratory system. So we wanted to get a little bit more detailed, so we'll follow the airway from the nose all the way down to those alveoli. And so the idea here is that the airway just moves air from the outside, but the goal is to get air to the alveoli. The alveoli is where you have that gas exchange. If you can get air to the alveoli, you can have gas exchange, and the patient's going to suffer. So the upper airway, this is just a little bit more detailed than the previous picture, but I do want to highlight a few things. So we talked about the nose, the opening, and we have the nasal passageways. You do have these turbinates that you don't really need to know right now, but that is what the air it gets coiled around in your nasal cavity, and it's humidified and heated. But the big part here is that air just goes down this airway passageway, and the back of the throat here, and the upper part behind the nose is called the nasopharynx, and then you have the oral cavity. Of course, the associated structures, the tongue, we'll talk about that in detail. But then you have the oropharynx, so the back of the throat here at the base of the tongue. Then you have the larynx, And if you notice here, so you have your tongue here, and the esophagus actually runs right behind the trachea. It's kind of cut off here in this picture, but that big tube back there would be the esophagus. So when we swallow, this flap has to cover our airway, or we choke. We can get a food bolus here. We can actually water goes down the wrong pipe, whatever. I'm sure we've all had that happen. But if the epiglottis has to close over this, so the epiglottis is considered an airway structure here. The larynx, this is the top of the very top of the trachea, and we have their vocal cords here. So the larynx is a lot of times called the voice box. You can feel the Adam's apple. If everyone has an Adam's apple, just some are more prominent than others, but if you can feel that little bump in your throat, that is the larynx right there. So again, just to see some of the different areas, the nasopharynx, we're going to have an airway called a nasopharyngeal airway, which is that flexible tube that goes into the nose that helps open the airway. And then we also have an oropharyngeal airway that we put in the mouth that holds the tongue off the back of the throat. When we look down at the back of the throat, this is what we see. This is the larynx with all these associated cartilage structures. So this would be the vocal cords here, and down here you can see the trachea right here. So that's just a pretty good picture of what it looks like at the base of the tongue, looking down into the patient's voice box. And when your paramedic or the physician intubates the patient, this is what we're looking at, or really that's what we want to look at. And we would put that breathing tube directly into the trachea. One thing to remember is that the larynx is the transition from the upper airway and the lower airway. So you sometimes see a question, what is the division between the upper and the lower airway? And that is the larynx, or the voice box. In this picture you can see the Adam's apple a little bit prominent there. So moving on to the lower airway, we have the trachea, and as you notice, it has these nice cartilage rings, or big horseshoe shapes rather, and in the back you have this smooth muscle. Remember that esophagus runs right behind the trachea, so when we swallow, this actually has to be a little bit flexible to allow the food bolus to go down behind it. But these rings are important because that is what holds this big airway open when we take a breath. And we'll go over the mechanics of ventilation, but basically when we take a breath, we're going to create a vacuum in our lungs, and if this was not cartilage, it would collapse onto itself. And another important structure is called the carina, and that is where you have the division between that trachea comes down and divides into these two main branches, the left and right main bronchus. And we'll look at that a little bit more in detail. So when I think about the respiratory tree, or the bronchial trees, or the bronchial tree, I think about literally a tree that's just upside down. So we take the tree and we turn it upside down, and you can see how we have the main trunk, and it branches off into the main branches, and you can see the twigs just get smaller and smaller and smaller, or the branches get smaller and smaller until you get these twigs, and then at the end of the twigs there's all the leaves, and that's where really the magic happens, just like the alveoli. That's where the magic happens. So you can think about this respiratory tree as just an upside down tree. So again, we have the trachea, and then we break off into the left and right main bronchus, and these just get smaller and smaller. So we'll point out some of these structures here in a minute. So there's the trachea, the carina, that's the division between the left and the right main bronchus. The right main bronchus. So again, the patient's right, so that's on the right side. The left main bronchus. And then you can see those smaller, the bronchi get smaller. So the smaller bronchi branches, and they get even smaller. And finally, they're going to get to a point. They're going to get so small that we can't see them anymore without a microscope, and we call those bronchioles. And those would be equivalent of the very small twigs at the end of all those branches in the tree. This is just another picture of the same thing. We're seeing the trachea that's cut off here, the left and right main bronchus. One thing to note is you see, so here's the carina, you see that the left bronchus kind of sticks out at an angle, and this one seems to just kind of go down. So the right bronchus, and the reason for that is it's got to accommodate the heart. But what you'll have is if patients have a hard time swallowing, maybe they've had a stroke, for example, and they swallow or they breathe in some of the food, like aspirate their food, or maybe even their vomit. A lot of times it's going to go straight down on the right side, and then they'll get an infection on the right lower side. That's usually where you see some aspiration pneumonia on the right side, and usually that's just because it's got a straight shot down. And again, that's just to accommodate the heart. So and the other point here is the left side has two lobes. You see the two main branches, the upper and the lower, and the right side actually has three lobes. So one here, one up here in the front, and then another one in the back down in the base. Just keep going down the respiratory tree to those smaller structures. I like this picture because you see this is a very large bronchus, and you can see the bronchial tree here just looks funny in the way it's cut, but again, more airway passages here. And then down here you can see these small, these are actually just vessels. You know that because you can kind of see they're meaty. They have kind of a thick lining. But then you see all these small little holes. Those are those small little bronchioles. You can't see the alveoli without a microscope, but you see all these little bumps in the or the little holes. Those are all the bronchioles, so very tiny airway passageways. And a lot of times students says it looks like a sponge. So this is the lung tissue. Just looks like a sponge. If you cut it straight down and you look inside, you'll see all these holes. And so the lungs are really spongy, and it's just it's packed with all these small airway passageways and alveoli. Again, you see the trachea. You see how the trunks get smaller and smaller and smaller. Those branches get smaller, and finally down here we get these very tiny bronchioles, and then at the very end of those we get those alveolar sacs, and each one of those little bumps is an alveolus. In plural, we call those alveoli. And that again is where we have the gas exchange. This is another showing you have those bronchioles ending with the alveolar sacs. Each of these little sphere structures is an alveolus, and I like this picture because it shows you the this computer image here of the capillaries. All of these alveoli, they have these capillaries surrounding it. So when the air enters the alveoli, it can diffuse out into the blood, and then the blood, of course, now has oxygen in it, and it goes back to the heart to be pumped to the rest of the body. Another picture showing you this lung tissue. See tons and tons of alveoli, and then this is just a gross surface picture on the left, and then on the right you actually do a cross section, so you see all these tiny little alveoli, and even some of the larger conducting bronchioles. Just another picture of the same thing. You're seeing bronchioles here. You're seeing pretty much everything else is alveoli, but just to point out a couple of them. And then you even have some blood vessels there. So the lung tissue is just really all this spongy tissue with some tubes and some blood vessels. And I like this picture because you can really see that those the 3D, the way those alveoli look. They're just inside. You have these hollow balls surrounded by capillaries, and the air comes down into them, and you have gas exchange. You have respiration down here in the alveoli. Taking a little bit of a step back, looking at some of the gross anatomy. Of course, we have two lungs. We already mentioned we have the 3 lobes on this side, the 2 lobes on this side. The heart, this whole area here is called the mediastinum. You have, this would be the vena cava. This would be the aorta. So this is a good picture. You can see this jugular vein draining down into the vena cava here, and the aorta. The arteries are a little bit more protected than these than the veins. But so you have the right atrium, the left atrium, and then of course the big left ventricle over here. A couple things to point out. You see this it's a little bit shiny. You see this covering over the lung. It's a little bit shining. That's actually a membrane covering the lung, and we'll talk about that. But first, a couple of notes here. You see this big pyramid over here. Excuse me, on the left. The lungs are mostly like a cone or a pyramid shape. You can see how it's kind of a pyramid shape here. With a pyramid, we have an apex and we have a base. So a lot of times we're talking about lung sounds. Imagine if the lungs had like a sponge, had just a bunch of fluid in it. So you would expect to maybe hear fluid in the bases, but maybe not so much in the apex. So that's something to note when we're listening to breath sounds on the chest. If we're down low towards the bottom of the rib cage, we're at the base, and the apex actually peaks up behind the collarbone. But for the most part, it's kind of protected by a lot of tissue there. So the collarbone would be right about here. So we're going to be listening to the apex about here. And we can make a distinction between breath sounds on the right side versus the left side, as well as the apex and the bases. And the other point to remember is this whole section. If you were to just plop this lung out and left with this big void in the chest cavity, you could fill that up with about 1,500 milliliters of fluid. So if you have a patient that's maybe lacerated their right pulmonary vein, you could be and just dumping fluid or blood into this chest cavity. We would you could lose up to about 1,500 milliliters of blood before it fills up, and then the blood can't go anywhere, and that's traditionally where we have the blood stopping, is when that chest cavity fills up. But 1,500 milliliters of blood is 1.5 liters of blood, and your patient's going to be really sick. if they've lost that much blood. So we mentioned the membrane over the lung. That would be the visceral pleura. So the pleura is just the coating of the lung there. A pleura really is a membrane. So you have a visceral pleura. That's that blue covering the in this picture, the blue covering the lung. And then we have a parietal pleura. And you can kind of see how we got that light blue between the muscle here and the dark blue. So that's the graphical picture here of the parietal pleura. And the parietal pleura is a membrane that lines the chest cavity. So we have these two membranes in contact with each other. As you can imagine, as the chest expands, the lung tissue is actually going to rub against each other. So you have a fluid in between those two. And that fluid is called pleura fluid. And it lubricates, so when those two tissues rub against each other, there's no friction and it doesn't hurt. But you can get an infection in between your pleura, and that would be called pleurisy, and very painful because those two membranes are now not lubricated and they're rubbing up against each other, and there's friction, and it hurts the patient every time they take a breath. The other purpose of the parietal pleura is that it helps the tissues stay in contact. For example, we breathe, and this will be a little bit clearer when we talk about the mechanics of breathing, but we, as I already mentioned, we create a vacuum, and to do that, the chest wall expands. And part of that fluid helps keep those two membranes in contact with each other. If you've ever taken two pieces of glass and put a little bit of water between them, it's really hard to pull those apart. They can slide against each other really well, but you can't pull them apart. And the pleural fluid acts very similar. The chest wall is going to go out, and it's going to pull the lung tissue with it. And you've ever heard of a collapsed lung, and that is when you get air, so that we get a little hole in our lung for whatever reason, either by disease like COPD, or we have an injury. We can get air in this space. There's not really a space, a pleural space, but if we introduce air into the chest cavity, the air will collect and create a space, and the lung is now no longer in contact with the chest wall. So when the patient takes a breath, the lung doesn't expand as much as it should. So we have a collapsed lung, is what lay people call it. But now we can call it by the medical term, which is air in the chest cavity. We call that a pneumothorax, when they get air in that chest cavity and prevent the lung tissue from coming in contact with the chest wall, and then of course that's gonna inhibit the lung tissue from fully expanding, so the patient's gonna have trouble breathing. You can also get blood in that space, and we call that a hemothorax, or blood in the chest cavity. So just a little bit of difference between infants, children, and adults. The nose and the mouth are smaller in the child versus the adult, so it's more easily obstructed by small objects, by blood bleeding into the airway, or swelling. If the patient is allergic to bees, for example, and their tongue swells, there's less room for swelling than in the adult for the kid. The tongue takes up more proportional space. It's easily to block the airway. The trachea is narrower, as you can see. It's also more flexible. So if you think about like a straw that's not a bendy straw and you flex it, it can kink off. And that's really important to know that if that very flexible, pliable trachea for the kid, if the other difference here is you notice the very large head proportionately than the adult. If we look at if we look here, the adult is lying completely supine and with the head on the floor and their back on the floor. Their airway is mostly in line, but if you do the same, because the kid has a proportionally larger head, if you do the same, their head is actually flexed forward, and if you're not careful, we can actually flex just like a straw that trachea and kink it off. So if you have a very critical kid and they're laying supine and they're not able to breathe on their own, or they're not conscious, so they can't move if their airway is kinked, and we lay them flat on the stretcher or on a backboard or something, we can actually kink off their airway and prevent them from breathing or breathing very well. So what we want to do is anytime we have to lay a kid supine, we actually want to pad their torso, bring their torso up so their airway is in a line. Some of the other differences, the cricoid cartilage is less developed. So if you're pressing on that airway, it may be easier to occlude the airway. The other thing is the chest wall is much softer and pliable. In the kid, the chest wall is less muscular, so they have a harder time breathing in. So they're going to use their diaphragm to generate that vacuum so that they can suck air down into their chest. Whereas an adult, we have very developed chest wall muscles, so we can compensate. We can breathe either with the chest wall or the diaphragm if we need to. The other important thing, that those ribs are cartilage. They're not as stiff as an adult's bone, so they can actually take a pretty good amount of trauma to the chest, and you won't notice, or they won't have broken ribs. Versus this guy gets hit in the chest with a bat, his ribs are going to be broken. He gets hit in the ribs with a bat, they might bounce back to the normal position, and when you're feeling, their chest wall is stable, and that might be a false sense of security for us. If they've taken that hit, they're definitely going to have some lung injury, but we won't have any rib fractures to help clue us in. So it's just something to consider if you have a pediatric patient that has chest trauma. Consider that they should, if it's a significant force, then they can still have lung injury without rib fractures. So that's it for this. The part 2 will continue with our respiratory and ventilation.